let's wrap up by talking about subcortical dementias. Now, these are a little bit different. There's multiple etiologies to this entity called subcortical dementia. And basically, you're looking for patients who have this distracted, easy fatigability of their cognition. And that's going to happen in the absence of some of those cortical findings that we've been talking about, both in this lecture and in the other ILA that you had. So they're not going to have any sort of aphasia or agnosia or any of those other things that we've been spending all this time talking about. These folks are going to have psychomotor slowing, some impaired concentration, difficulty reading, forgetfulness. Basically, they just seem a little bit, I guess, whiffy might be the best word to describe these folks. One thing that I will say is that oftentimes when you start working in the clinics, you're going to have a lot of patients, especially in their 40s and their 50s, who have symptoms kind of like this. And more often than not, these patients, if they're in their 40s and their 50s, even sometimes in their 60s, they often have, if they have a subcortical dementia, some sort of disturbance of sleep or their mood. So I really like to screen for those things. In fact, oftentimes you can eventually get yourself to a diagnosis of a sleep issue like a sleep apnea, starting from a subcortical dementia. So whenever someone comes in, especially if they're in their 40s or 50s, I ask about what their mood is like, what are they doing on a daily basis, what is their sleep like, how many hours of good sleep do they feel like they get every night? And unsurprisingly, a lot of these patients, when they seriously think about the answer to that question about sleep, they give me back an answer about saying that they get 4 or 5 hours of good sleep a night, if that. So another thing that's worth mentioning is that when we are trying to work up these patients with any of those dementias, either here or in the last ILA that we've been talking about, you really want to look for another explanation for their dementia, all right? So we want to look for things that we might be able to reverse. So your basic things that you want to look for are at the very least a B12, and I think you guys talked about this a little bit in terms of spinal cord findings, but we'll expand on that a little bit. You're going to want to check at least a TSH because you can get some overall psychomotor slowing and cognitive slowing from hypothyroidism. And then you're going to want to get some sort of head imaging, a head MRI or a head CT to look for some sort of structural finding. Back in the day, people actually used to want to get RPRs and VDRLs to look for neurosyphilis, but that's no longer part of the standard practice, although in the right clinical setting, you might want to look for that. I personally have not looked for that, and I don't look for that in patients as a first sweep anymore. So the first of these, so the next thing we'll talk about is normal pressure hydrocephalus. So basically, there's this triad that you'll probably hear about as you're studying for you're studying for this and for step one of wet, wacky, and wobbly. It's this triad that people are referring to gait disturbance, a subcortical dementia like we've been talking about, and urinary incontinence. And basically what's happening is that the CSF is not being absorbed by the arachnoid villi. So oftentimes these patients have a history of something that would lead them to that, whether it be a severe head trauma or bacterial meningitis decades before. And what you're looking for is you'll do some head imaging and you'll see enlarged lateral ventricles with the rest of the cell side looking okay, actually. One thing I'll mention is this gait apraxia that you may see with this. There's something called the magnetic gait that you can see with that, where basically people's arm swing and posture looks okay, but there's this shuffling quality to it where basically it looks like the patient, their feet are stuck to the floor. So each step just to lift their feet off the ground takes a lot of effort. So if people mention magnetic gait, they're really referring to the gait that you can see in a normal pressure hydrocephalus. So in real life, this is actually very tricky to diagnose because you get a lot of elderly patients who have over the course of time, you'll have a lot of atrophy in the sulci, along with atrophy here in the lateral ventricle. So it becomes very difficult to use the imaging to make the diagnosis. A lot of those patients have incontinence for one reason or the other. And a lot of those patients have even the beginnings of some dementia or mild cognitive impairment. So I started to change my tune and think about who would benefit the most from the treatment for that, which is a ventriculoperitoneal shunt. And so you're looking for patients who have those risk factors that we talked about before, a history of head trauma or a meningitis. And there's other things too. So dementia it hasn't been going on for too long, so less than 2 years. And their gait disturbance, that difficulty with walking is one of their first symptoms. No history of alcohol abuse to go with them. And an improvement after you get a large volume lumbar puncture. So we talked about the gait difficulty, and the idea is that you watch them walk up and down the hall. You take a large sample of CSF after doing a lumbar puncture, and then there should be some improvement in their walk right after that. So that's what you classically can find in this diagnosis. All right, let's close off with a couple more settings where you can get a subcortical dementia. So B12 deficiency, you guys have probably heard the term subacute combined degeneration. So when I think of B12 deficiency, we're thinking about a subcortical dementia plus, you guys have probably talked about the spinal cord findings. So your dorsal columns and your cortical spinal tracts can get affected. And then also in B12, you can see a large fiber polyneuropathy that can happen as well. So all of these things are possible with B12 deficiencies. So you will see us in about 2 years when you start to work with the neurology folks, and even with some of the internal medicine and some of the other subspecialties, when some of these symptoms pop up, we'll often just order a B12 to see if it's low, because it can cause a lot of different things. So the last thing we'll talk about is hypothyroidism. So with this, you'll have the slow memory retrieval, overall just the slow movements, both cognitively and motor-wise. So the psychomotor slowing. That primary hypothyroidism can be fairly common in the elderly. One of the things to note, though, is that even if you catch this hypothyroidism and you treat it, you may not necessarily reverse the dementia, but you can at least stop the decline with that treatment. All right, guys, so we're done. So we spent a little bit of time talking about some of the classic cortical dementias, and then spent a little more time talking about some of your subcortical dementias as well. Like I said, if you haven't done so already, make sure that you review the behavioral neurology ILA. Think of this one and that ILA as a pairing. They make the most sense coming together, okay? All right, guys, take care.